principle of X-ray technology, where the attenuation coefficient of the soft tissue is being utilized to calculate the difference of various tissues. Using this principle, the CT allows the reconstruction of the density of the body structure. So, multi-slice CT scan, various positions can be taken. CT PNS itself can be taken in supine position or in prone position with neck extension. So that's the clear coronal view. So both the positions it can be taken. Various reconstructions can be done like axial, coronal, sagittal, and reconstructive images can be done. It could be a plain CT or it could be a contrast enhanced CT. So basically we should know two things. There is window width. Basically it talks about the contrast. Increasing the window width will cause lower the contrast and decreasing it will increase the contrast. Same way, window's length is about the brightness. So by adjusting both window's width and length, we'll be able to see the images much more clearer, and we'll be able to differentiate the bony structure and soft tissue structure, and various windows width and length is needed to see the structures clearly. For example, I will show you how it will be utilized when we want to see the lung tissue or brain parenchyma or a soft tissue or paranasal sinus, etc. Okay, here you can see this is the default window length of the lungs. If you change it to see the pulmonary windows with an length, you can see the pulmonary structures much better. If you change into soft tissue, we'll be able to see the soft tissue better. So here, if we see these are all default settings in the software. If you change it to brain, CT brain, that changes. So that's how the windows will. But manually also, we can adjust that difference. Another thing, what we commonly speak is about soft tissue window and bone window. So soft tissue window is typically with a wider window width and the window length, where we'll be able to see the soft tissue much better, and bony demarcations will not be there. Bone will be like full white, radio opaque. And bone window, the soft tissue will be looking much more lesser contrast with little more brightness, but the bone, ossicular chain, the foramens, all those things will be much more clearer, right? So this is a CT-PNS where the coronal view is being taken in a patient in prone position with the neck extension. So here the cuts will be in coronal angle itself. So there is no reconstruction being done here. The advantage is the patient is almost like in a standing position where the fluid levels in the sinuses, especially in the maxillary sinus or frontal sinus or in the middle ear, all will be gravity oriented and you will be able to see the fluid level clearly. If the patient is going to be in supine position and if you are going to take axial views and if you reconstruct it to the coronal view, then the soft tissue inside the sinuses remain doubt whether it is soft tissue or is it fluid, etc. Right. Before this, I used to prefer DICOM viewers. I am using a Mac where Horos is the software being used here. If you are using Windows system, you can use Radiant software or different softwares are available, DICOM viewers, so that can be used. I am opening one patient. So this is a HRCT of the paranasal sinus, and it's in axial view. So that's the default view. So here you can see the thickness. This is 500 micron. That is almost 0.5 mm of cuts being taken. Okay. So here the image size is being mentioned here. 512 into 512. That's the megapixels. And what we are seeing is little magnified view. That's the view what we are seeing there. So first, we are just going from above downwards and seeing like this, right? So here there are various options available. I am just changing into orientation into coronal. So when we read CTPNS, we go from anterior to posterior, superior to inferior, like that. Either way we can go. First, you run through to see whether there is any gross abnormality, or are we missing anything, or the scan is being taken properly, or are we missing anything. So all those things you just run through and have a quick look. Just how I came from posterior to anterior, you can go from anterior to posterior to posterior to anterior and see everything is okay. Then see the bony structure. Then see the sinuses. Then see the smaller structures. Okay? So from anterior to posterior we are going to go. So here we are seeing the nostrils and going posterior. Till now there is no bony structure we have encountered. So now we can see the nasal bone starts appearing, and you can see antenasal spine, and usually this is right side and that's left side by default. Even though if it is not mentioned, here it is mentioned right and left, that's default. Now I am going a little more posterior, sinuses starts appearing, and you can see what is this structure. Anyone? I want to be more interactive.
Incisive.
Is basically, I am not showing any pathology here. 90% it will be of normal. All is about anatomy. What is that?
Incisive foramen.
Fistula?
Incisive.
Incisive foramen. Okay, so that's the incisive foramen, which is coming like premaxilla, between premaxilla and maxilla. And again I'm going anterior and coming posterior. So you can see the septum, bony septum, which is slightly deviated to the left side. It's not touching the lateral wall. And you can see the orbit coming in. And now the frontal process of the maxilla started coming. The maxillary sinus, frontal sinus you could see, and going a little posterior, multiple septae looks like, and maxillary sinus started appearing along with inferior turbinates. And you can see a couple of air cells here. So they are agar-nasal. Right? So agar-nasals are present anterior to middle turbinate and uncinate process. So these are all agar-nasal. So now you can see the middle turbinate started appearing. Am I right? So what is this structure? Nasolacrimal duct. So this is orbit, lacrimal fossa. This is lacrimal fossa where the lacrimal sac is there, and you can see that the lacrimal duct, nasolacrimal duct, coming and opening into the inferior meatus. So this is the left side and right side nasolacrimal duct opening into the inferior meatus. Okay, so we have seen the nasolacrimal duct system. Again coming from anterior to posterior. Next I would like to show the frontal. So there are a lot of septae inside. So you have to remember these are all one level you are seeing. So even if there is a small bump or a small projection inside the anterior or frontal size, you may see like there are multiple septae. It may not be a complete septae. So that you have to keep in mind. So this is cystoid highlight. This one, lateral lamella, and incomplete. So again from anterior to posterior. So frontal sinus, concentrate on frontal sinus, not much developed on the right side. Am I right? So not much developed on the right side, left side well developed, and that's the frontal pathway, drainage pathway, lot of agonizing cells are there. So next you concentrate on the middle turbinate, how it is. So these are all agonized. So here you see the middle turbinate, right side, left side. Concentrate on that middle turbinate. So how it is attached. You can see that nicely. It's all to the cubiform plate. Then it curves this up, and that's the final attachment to the lateral wall. So on either side. Clear? So that's the middle turbinate. So next I would like to see the unsnake process. So nasolacrimal duct, I'm showing on the right side. This is the unsnake process. Clear? That's the horizontal part of the unsnake. So there is a vertical component which will be anterior to this. So that is very difficult to differentiate in coronal view because the plane of the structure is also coronal. If you follow this structure, you may be able to see the unsnake, the vertical component. And coming anterior, so this is the what is the structure? Concha bulla. Right? Am I right? Bulla ethmoidalis. Concha bullosa is the axil within the middle turbinate, concha. So what is this?
Accessory also.
Accessory ostium. So coming from anterior to posterior again, orient yourself. So you can see the middle turbinate, unsnake, and the horizontal part of the unsnake, which is part of inferior turbinate bone, and that is the osteometal complex. That's osteometal opening. That's not fontanelle or accessory ostium. But when you go posterior, there is opening here. That is posterior fontanelle or accessory ostium. Here. So what is this structure? Superior turbinate. So we have seen inferior turbinate, middle turbinate, superior turbinate, unsnake, accessory ostium, how the maxillary sinus opening, frontal sinus opening, everything. So now again coming anterior to posterior. So here I would like to see something. What is that? Anterior ethmoidal artery. So this here, the anterior ethmoid is almost nearer to the level of roof. So it's very difficult to injure unless you injure the cubiform plate itself, fovea ethmoidalis, right? So that is anterior ethmoidal artery. You can see clearly on both sides. Clear? If you are not able to follow, please let me know. Because we have very short time. Unless you stop and ask, I will be proceeding further. So next I am going still posterior, and again you will be able to see sometimes the posterior ethmoidal artery. Can you see here? That's posterior ethmoidal artery. Clear? Most of the times we will be able to appreciate, but sometimes we will not be able to appreciate clearly this posterior ethmoidal artery. So all these are posterior ethmoids, and up to this is posterior ethmoid. And what is this?
Onodi.
This is onodi and this is sphenoid. Clear? So this is which side sphenoid? left side sphenoid. So that is intersphenoid septum, that is zoonoid. And right side sphenoid is smaller. All clear? So what is this bone? Rostrum of sphenoid. Clear, perfect. So now, when we go posterior, so the maxillary sinus posterior wall disappears. So what is this area? Pterygoparietal fossa. And going little posterior, so what is this structure? Foramen rotatum. What structure passes through? Maxillary now. So you can see that foramen rotatum. What is this? Vidian. Perfect. So we have seen foramen rotatum, Vidian canal. So what else you want to see? Next foramen nearby. Oval. So this is foramen oval. Much more posterior and lateral. Is it clear? So coming to anterior, you can see the orbit, you can see the intraorbital muscles. Okay, so now we can adjust window length with everything to see the muscles better. Oh, that is actually a different contrast than what I see in the monitor. Actually, it is very different from what I see in this screen. But anyhow, so by adjusting this, you will be able to clearly see the muscles, intraocular muscles also. So here I can see the medial rectus, superior oblique, inferior rectus, inferior oblique, and lateral rectus. So everything can be clearly seen. So when you go and trace this posteriorly, you can see the optic nerve in the middle. This is, which is going like this, you can see. So where it goes? Goes to orbital apex, and then what is this structure?
Superior
Yes, superior orbital fissure. So here all the cranial nerves and the optic nerve goes here, and this is the area of cavernous sinus with internal carotid artery, which is going to be the lateral wall of the sphenoid. Is it clear and oriented? Can you orient yourself and coming again? So this is the orbit going posterior towards orbital apex, and when we go a little more posterior, the optic nerve almost will be medial, so that when you are doing orbital decompression or optic nerve decompression, just opening up on that area, you will be able to see the optic nerve. So this is orbital apex. So going posterior, and that will be your superior orbital fissure, and this will be your inferior orbital fissure. So through inferior orbital fissure, what is the structure coming? Infraorbital nerve. So infraorbital nerve is a continuation of maxillary nerve. So if you trace that, it will end up in foramen rotatum, through which the maxillary nerve comes and goes to pterygoparietal fossa, and if you follow that inferior orbital fissure, you will be able to appreciate that it is in the floor of the orbit or the roof of the maxillary sinus, and it comes out through the infraorbital foramen. This is the one. This is infraorbital foramen. Right. So just trace this posteriorly. It is very flat here. It goes like this. Goes like this, and that will open up into the infraorbital fissure. Clear? Can you follow? And inferior orbital fissure, if you follow, that will open up into the pterygoparietal fossa and goes into foramen rotatum. So we have seen all the sinuses and few important structures. Now we will see the spinocardial foramen in axial view outlook. Okay, this axial view, you can see the optic nerve clearly and how medial it is coming, and you will know exactly where you want to open up to do optic nerve decompression. Can you appreciate that? That will go into the, that's the optic chiasm, both sides. So this is the maxillary sinus in axial view. So what is this structure?
Lateral.
Lateral pterygoid plate and medial pterygoid plate, and coming superior, can you see that? So that's a spinocardial foramen region, which opens up into the nasal cavity. Okay, so anyone did notice anything in the ear in this patient, middle ear? Master? Did anyone? So always have a look when you are seeing CT/PNS, look for the temporal bone, and when you are seeing temporal bone, look for the paranasal sinus. See here. Full of soft tissue. Actually, this patient came for nasal problem. See the middle ear, mastoid. Almost this is actually keratosis operans with canal erosion. See how much it is eroded. Okay, so the patient may not be having severe symptoms or discharge something, but there can be some other pathology you may be able to find out. So keep in mind. Right. So with that, I stop CT/PNS. Let us see how we can use navigation in this. So this is the setup. So all be connected. The patient is in position. And this is how it is being done. Here we have a demo. External camera, can you focus on that?
Camera focus.
Can you focus on that aspect? So this will be the position of the patient, and here is the emitter, which has to be creating a magnetic field surrounding this area where we are going to operate. And every instrument has to be registered, and that all I will be showing in 3 minutes. And this is patient reference tracker, patient tracker. That's all attached. Can you focus here? This view. External camera. Zoom out a little bit. So basically, navigation system helps us to identify and compare with our city finding to know the exact place and position of our instrument. Yes. So this is the patient tracker. This is being already placed on the patient's forehead, and this is a demo piece. And this piece, what I'm showing here, show this. This is going to emit electromagnetic radiation around this area. Clear? So that will be picked up by the instruments. There are various instruments available, like straight suction, curved suction, and we can check in between whether whether our instrument is in right position or not, everything. So the CT PNS what we have done has been already loaded into the system, so that the system recognizes where the instrument is. Right. So that is should be done at least with minimum 1 millimeter thickness, and what we have done is much more thinner version. And this has to be, as I told you, it has to be nearer to the operating field. And each device has one connector. So that is going to emit and absorb the radiation from this device and going to conduct to the system. So this is axiom box. So there are some 4-6 devices can be connected at the same time. Reference is contact class. Best contact class. So first step is going to be registering. That means this anatomy of the patient is going to be compared, correlated with the CT finding. So we will know exactly where the tip is and then the CTPNS of where it is. So both will be compared and correlated. So here the verification is successful. Can we have this monitor video also? This monitor. So you heard that sound, right? The verification is successful. This is called registration probe. So with this we are going to start the registration. Next over. So now we have to draw this direction where we will be expecting our surgical field continuously without lifting it from the air till it completes, or towards the mostly the body region up to the tip of the nose. So like this we register. So now we can see wherever we have gone, all has been tracked and has been registered. So with this instrument, this is I'm just showing. So when we touch the nose, tip of the nose, you can see in all three axial views, this is coronal, and that one is sagittal, and that is axial. So in all three views we will be able to confirm. And this fourth view, which is on the right lower, can be an endoscopic view. This has been connected. No, into this fourth one. So when we are doing surgery, so we can have the entire view of the endoscopic image, or in this four views, one window we can use it for endoscope. So that also possible, so that simultaneously we can see and operate. Now when we are changing the instrument, if you are going to change into suction tip, the instrument has to be registered so that the instrument, system will understand that you are using the straight suction, for which you have to fix one detector. So this now connector. Place it on this place. Put under the
external camera. External camera.
External camera.
External camera.
External camera.
External camera. Mannequin வரல.
Yes, yes, okay.
So when you place it here, this instrument will be registered and registered straight suction. Similarly,
Monitor and mannequin coming in.
monitor coming. Connect this. Give me one more. The power section.
Mannequin.
Can you show the emitter here? Yeah. So you can see that 70-degree curve section is being detected.
Picture in picture போடுங்க. PIP போடுங்க. PIP ல ஒன்னு வந்து mannequin இன்னொன்னு வந்து monitor coming. Yes. Near.
Can you see that? So when you register with the 70-degree curve section, you will be able to see that that's being detected, and then when you introduce that, the system will be able to recognize that you are introducing the curve section, and it will know the distance between the device and the tip. Can I have this presentation? So this is how registration will be done, and so registration will be successful. So this is all this. So this is what I told you. One window you can have the surgical endoscopic view, and simultaneously you can monitor all three views when your instrument is being introduced. So here, the green dot will tell you where you are. Can you see there? Where is the green dot? It is in the anterior surface of the sphenoid. So that we can compare and make sure that you are going to open into the sphenoid, not into the posterior fossa and posteriorly or into the anterior fossa. So next you can see how it's being used in the frontal. Here the curve section is being introduced, and in all three views you are able to see where our instrument tip is. So it is very close to lamina, that is more lateral, and you can see confirm it in the axial view how far it is and how much posterior to the frontal view. Our main reference for frontal entry is our frontal peak bone. So you know we are very much closer to the frontal peak. So I am using 0 degree only. I am just hugging the frontal peak, the bone, and going in. So my instrument is going into, now it is going towards the fovea. It's more posterior. So that you will be able to understand better. You can see that in the coronal view. I am very much posterior. So this entire thing is anterior cranial fossa. Can you see that white color? So that is it. You can compare it here, where we are. Is it clear? So how much it is? So the next video you'll be able to appreciate. So that's the lateralmost part of the maxillary sinus. There was actually intermaxillary septum. I don't know whether you can appreciate that in this coronal view. Actually, this is one septum which is dividing the maxillary sinus as if it was looking like a Haller cell. We thought actually we entered into the orbit like that kind of situation. So this is actually with 70 degree. I'm seeing the maxillary sinus. I'm just replaying it here. So here at the level of lamina, now coming down, the instrument is going into there. You can see a partition there. So that is, the entire thing is maxillary sinus, but there is a partition. I am using 70 degree curved suction tracker, and you can see the frontal sinus there. It is completely closed. That's blocked. The sinus is. I'll just pause it and show you. Now you can see in the green, it is entering into the frontal sinus. And then now you can see we are completely inside the, what we are seeing is the inside the frontal sinus. So this area has been opened up and then it is confirmed before opening the frontal sinus when there is complete block. So this will be a device which you will be able to use it, especially in revision surgeries and frontal sinus cases where you feel more confident, but still the anatomy plays a vital role and nothing can beat it. Even if the instrument may sometimes go wrong, you have to keep your antennas all around. Right? So we have another 10 minutes only. I don't know whether.
No, no problem. You can
Continue.
no issues. 10 minutes you can extend. They are all very jam-packed. See, pin drop silence. They are enjoying.
Right. I want more discussion than that. So
Please.
CT neck. So this again is full of anatomy. So it's mainly to visualize the deep neck structures where we can't easily, and most commonly we ask for infection or tumor. Sometimes foreign body and to evaluate the disease spread. So anatomy is the key for studying CT neck. So we have to categorize the neck depending upon the triangles and spaces. These two you have to understand and remember. Accordingly, we will be able to see what all we have to see. So triangles, anterior triangle and posterior triangle, which we all know. Muscles, we broadly classify as suprahead muscles and infrahead muscles. And other muscles are there, but broad classification I am saying. There are 9 cartilages around. Sometimes they will be calcified, so that should not be mistaken for foreign body. Thyroid gland is another main structure which we would like to see. And bone structures, the only one which is hyoid bone, above is mandible, lower down it's a spine of the cervical vertebra, clavicle, manubrium sternum, and lymph nodes and vertebra. So compartment wise, there are 3 compartments. The vertebral compartment, that's the major part, which is posterior, around the cervical vertebra, perispinal muscles, prevertebral muscles, paraspinal muscles, etc. Next, the middle compartment, that's visceral compartment, which has trachea, larynx, pharynx, thyroid, parathyroid, even parotid, submandibular, sublingual. So all can be included as visceral compartment. And then the vascular compartment, that is carotid space, which has common carotid, non-carotid, external carotid, with intrajugular vein and vagus nerve, cervical sympathetic chain, everything together. So there are 3 major compartments. So all being divided by facial planes. So facial plane broadly superficial and deep cervical fascia. Superficial cervical fascia is a very loose areolar tissue from between the surface and the platysma, skin and the platysma. The deep cervical fascia is divided into superficial, middle, and deep. The superficial layer from mandible to mandible, master process, occiput, and down up to the mandibular sternum and the clavicle. It encloses the sternocleidomastoid and trapezius. These two muscles will be encompassed by the superficial layer of the deep cervical fascia. So the middle layer from skull base inferiorly to the mediastinum. The deep layer also from skull base to mediastinum, but that is the prevertebral layer. And the alar fascia, pubopharyngeal fascia, dangerous base, all those things are there. So the middle layer is going to encompass all the infrahead muscles, visceral compartment, suprahead muscles, all those things. Clear? So we'll go on to the next thing. All three layers contribute to form the carotid fascia. That is carotid space fascia. So triangles of the neck, anterior triangle, posterior triangle, anterior triangle submandibular, submental, carotid, muscular triangle, posterior triangle, occipital triangle, and subclavian triangle. This reference is very important when you see a X-ray neck or a CT neck. C1 corresponds to the heart palate. C2 corresponds to the mandible. Heart palate, mandible. C3 corresponds to the hyoid bone. C4 and C5, thyroid cartilage is a bit more broader, so C4 and C5 corresponds to thyroid cartilage, and C6 or 7 cricoid cartilage. Sometimes we will be able to see T1 also, if the neck is longer like this. And when you keep your hand on the back, and if you see one prominent spine, the back side, the lower part, that is the cervical spine 7, C7. Clear? So that's the longest spinous process, and that's 7. So this is very important because all the muscle plane, what we say in anatomical dissection, will not be able to appreciate clearly in the CT. So when you see any node or swelling beneath C3, that means infrahyoid. So level of lymph node, everything will change. So if you see the same swelling above the hyoid, that means it is level 2. So all those you have to keep in mind when you are seeing neck at various levels. So the muscles, platysma, sternocleidomastoid, and trapezius in the superficial, and deep muscles, suprahyoid, infrahyoid. And when you remove both suprahyoid and infrahyoid, the next compartment will be scalene muscles. So usually we don't remember the scalene muscles, so that's the next group of muscles. And behind next will be the prevertebral muscles, and behind will be suboccipital muscles and paravertebral muscles. So visceral compartment from pharynx to trachea will be going through and seeing in diagram images, go up and down, see 2-3 times. So we'll be seeing the pharynx, larynx, air columns inside, trachea, larynx, and also thyroid. And sometimes parotid also will be able to see. Parotids and submandibular glands are able to. Depending upon the spaces, I will be explaining to you. So here you can see a huge goiter which is actually blocking the thoracic inlet. So when you see a thyroid neck, you have to, you can remember that it's almost symmetrical. So always compare right and left and see for any difference, all the facial planes, etc. So here you can see there is something blackish or hyperintense compared to other part of the. When you give a contrast, you can see that how it enhances. I'm not going to talk about the pathology part, right? So cartilage. This is actually the classical view when you see a coronal section of this area, and you can see the entire larynx, thyroid cartilage, hyoid bone, cricoid cartilage. This view will tell you whether there is any subglottic spread of any tumor or mass, etc. So these all things we will be seeing little more in detail when we go through the diagram images. So what you are seeing here above the hyoid is valvular, median glossopiclotic fold, and this is supraglottis, this is false vocal cord, true vocal cord, subglottic area, and this is the cricket cartilage. Clear? So what is this black thing?
Hendrik.
That's paraglottic space. So when you see any swelling here and this paraglottic space, the blackish shadow is distorted, means there is involvement of paraglottic space. Okay, this is another most important slide which we will be looking at when you read a CT scan. Right. So broadly we classify as suprahyoid and infrahyoid. So we see CT neck in 90% in axial view, and then only we will be switching over to other views, sagittal, coronal, etc. So when we see, we stop at the level of hyoid, go up and down again and again, and then we go infrahyoid and see the look for anomalies. So suprahyoid, there are so many spaces: sublingual, submandibular, peritonsillar, then parapharyngeal and pharyngeal mucosa, then outside masticator, carotid, and then again prevertebral, retropharyngeal space, dangerous space, and perivertebral space. So this is how we classify the suprahyoid region. Again, I am repeating. Infrahyoid, mainly the visceral compartment, the cartilage, trachea, thyroid cartilage, larynx, trachea, and the carotid space. Carotid space is again suprahyoid and infrahyoid, and then retropharyngeal space, dangerous space, and perivertebral space. So when you see here, we first see this diagram. So here you can see this is the axial view at the plane CT, this is contrast CT, axial view at the level of mandible. So what we are seeing here is the sublingual space, and little posterior will be the submandibular space. And what you are seeing here is the epiglottis, and that's the tongue base, and that's the valvula. Okay, so same in coronal view. This is the, when you see little more anterior, that is sublingual space. When you see posterior, it will be submandibular space. At one point, both will be seen. That's the point here. So this is sublingual. This is, how do you know whether it is anterior or posterior? By seeing the maxillary sinus. When you are seeing almost the part of the maxillary sinus along with posterior side and all, that is, we are almost posterior. And these are all images, right? When you see diagram, you will be able to appreciate clearly when you run through anterior to posterior. But in still images like this, these are all the comparative structures to know or understand whether we are anterior or posterior. Here it is almost posterior, where you are seeing both sublingual space and submandibular space. So next, if you see this image, you can see what is this bone? I'm keep talking. What is this bone? Mandible?
Ramus.
Ramus. Ascending ramus of mandible. So this structure, which is lateral, masseter, and medial,
Pterygoid.
medial pterygoid. So here, this entire space is masticator space, and this structure, mandible, maxilla. You can appreciate the shape of the bone. That is the maxilla or upper alveolar margin. So that is maxilla, and this is mandible, and this is the masticator space. Clear? And posterior to that is parotid space, where you have the parotid gland. And medial to that and posterior to the masticator space is parapharyngeal space, where the carotids, styloid process, everything will be there. So that will become divided as pre-styloid compartment, post-styloid compartment, etc. And little more medial or the mid plane is retropharyngeal space. Clear? So again, So this around the mandible is masticated space. This is the parotid space. This is carotid, and this entire area is parapharyngeal space, and this is the retropharyngeal space, and posteriorly all these are perivertebral space. So both sides. When we talk about infrahiatal, so this is number one is, and what is the space? Visceral space. What you are seeing is the thyroid cartilage. Okay, so 2 is carotid space. You can see the vessels. 3 is
Retro.
retropharyngeal space. 4,
Para.
parotid will not come below hyoid. So that is a soft tissue area. What is this muscle?
Sternocleidomastoid.
Sternocleidomastoid. So this is posterior triangle space. And what is this structure? Anyone?
External.
External jugular vein. So something which is lateral and over the sternocleidomastoid, that is external jugular vein. This is a contrast enhanced CT. Okay. So various levels of lymph nodes, submental, submandibular, I'm not going through. So this is another important slide. You should understand various spaces, what are the contents, and what do we expect out of any pathology in that area. Sometimes I would have missed something, but these are the common things which we look for. When, for example, in a sublingual space, we will be expecting any swelling. If you see there, it could be a ranula or Ludwig's angina, that much edema, or even submandibular duct silolithiosis will be there, not in the submandibular space. So submandibular duct runs to that area, and if you see any radiopaque structure there, that will be submandibular silolithiosis. So submandibular space, silodinitis, silolithiosis, Ludwig's also can come there. So accordingly to different types of various spaces, we see that. So before going through the diagram image, I will see how you should see a CT neck. First, check the patient name and age, gender, and date of birth, etc. Date of the procedure taken, whether this is very old or something. That confusion can commonly happen. So make sure and know the patient symptom and history and what you are looking for. Assess the scan from skull base to thoracic inlet. Just go through from skull base to thoracic inlet and evaluate the image quality or artifacts, etc. Scroll through all images in all planes and identify for any focused anomaly. And use appropriate window when you are looking for certain things. When you are looking for a soft tissue pathology, look for that. When you look for any lung pathology, look in that window's width and length. If you are looking for any bony structure, so maxilla, mandible, hyoid, so do according. First, see the bone structure. Then see the cervical spine and cervical canal, whether there is any osteophytes which is blocking the esophagus, cervical esophagus, so all those things you have a look. And then look for airway and aerodigestive tract, and then see for vascular structures, then visceral glands, and then finally the lymph nodes. And muscles and fascia and various spaces, soft tissue and fat planes in there. And then look for the thoracic inlet and upper mediastinum, the last. And then correlate with the clinical findings and formulate a structured report. So here I stop. I'll take another maybe 10 minutes. That's the first cervical vertebra. What is this? Anyone?
Odontoid.
Odontoid process. That's the second cervical vertebra, odontoid process. Coming down. So you are seeing the upper alveolar margin or maxilla with the incisor foramen, and what you are seeing on the sides are the ramus of the mandible. Going down, So you can see here, see, this is the advantage of using Dicom. See here, I will just zoom it a little bit. So that's a maxilla. When you just scroll down, still you are seeing the teeth, and at one point you are able to see something on the inner side. So that's where the transition between the upper and lower teeth, that is maxilla and mandible happening. And this part is mandible, lower alveolar margin. And you can see what is the structure? Foramen for
Inferior alveolar.
inferior alveolar nerve, and you can see how it exits through the mental foramen.
foramen.
Okay, so that's mandible looks normal, and hyoid comes. Hyoid is still in place and it's fine. And you can see the thyroid cartilage. Cricoid is not much ossified, and trachea and coming down, and that's the clavicle, and that's mandibular sterni, and the first rib comes here. So these are all first rib, and lung shadows being seen. Clear? So now, if you change this window, as I told you, see the pulmonary, you're able to see the lungs clearly. Let us go to default windows. So now you can see here, let me complete it here now itself. So what is the structure?
Arch.
Arch of aorta. And another thing you have to remember, same in CT neck also. This is right side and that is left side. So this is right side, that's left side. Patient is like lying down in supine position, as if the head end is left side and foot end is this side, right? So this is right side, this is left side, this is arch of aorta. So when you come out, just now we will finish up the vascular compartment. When you come out, you are able to appreciate three structures, three dots, 1, 2, 3. 1, 2, 3. So right side, this is right brachiocephalic, dividing into, you can see that, follow my arrow, coming up, right subclavian, here it goes. Okay, so this I will show you with contrast, so that will be better. Can you see the difference? So now it is still with contrast, that's arch of aorta. Now three structures clearly seen. So that is, what is this one? Left side.
Subclavian.
Left subclavian, just follow that. So this is left common carotid, left subclavian. So that common carotid goes anterior and left subclavian goes this way. And this is common carotid, just follow that. That's left common carotid. So at what point it bifurcates?
Hyoid.
Into internal and external. See that? Still it has not divided. Coming up. So now you have started seeing the hyoid. Still it is similar structure. It's becoming more flatter and dividing into two. Can you appreciate the division? So this is internal carotid and external carotid. Clear? So this is common carotid coming up. At the level of hyoid, it divides into two, internal carotid and external carotid. External carotid is internal, internal carotid is external. So this is right side and that is left side. What is this structure?
IJ.
IJV, internal jugular vein on this side and this is from left side. So when the contrast CT is being taken, there are arterial phase and venous phase. So when you are taking a film in arterial phase, the arteries are filled with high contrast, and when you take it in venous phase, the veins will be much more prominent. So carotids you can even trace up to the skull base. Okay, we'll stop there. Now we'll come to near the skull base. From skull base, the first base what we will be seeing is the carotid, and then from superior to inferior we come down. Okay, so now this is skull base. When you come down, you can see the external canal. Once you cross the external canal, the mastoid tip, and this is carotid gland. So we all agree to that, right? No doubt about it. And here you see, what is this? What is that? That's the
Head of the man. Head of the man.
head of the mandible, condyle of the mandible. And this is the coronoid process. Correct? Correct?
Yeah.
So what is this? Coming from the
Lateral pterygoid.
lateral pterygoid plate to
The neck of them.
so that is the lateral pterygoid muscle. And this is coronoid process, the muscle which is attached with the temporalis.
Temporalis.
So all these muscles also will be able to see. This is very important when you come across any fractures in this area. Okay. So now both condylar process and coronoid process join and form the ascending ramus of the mandible. And so this entire soft tissue here is the parotid gland. And when you go a little further down, you are able to see it is extending medial to the mandible also. So that is the
Deep lobe.
deep lobe of the parotid. And you can see all the great vessels here. Is it clear? Can you mark out the parotid how it is? So this entire area is parotid space. And when you come further down, that's where the medial pterygoid and mesothelium is there. Even medial pterygoid, lateral pterygoid, mesothelium, everything together only it is mesotic space, masticator space, right? So now coming further down, it's now at the level of mandible. So you can see various planes. So when you see this heterogeneous black, dark black, gray, different shades, that means it is normal. And sometimes even you will be able to see the fibers of the muscles, that is all these horizontal longitudinal muscles, genio, hyoid, everything. So here when you see any abnormalities, swelling, edema, that is sublingual space. So when you come little posterior, this area is submandibular space, a submandibular gland. Is it clear?
Yeah.
Can you follow? So I'm coming up. So you follow the parotid gland. You can differentiate the tissue color. Coming down. Okay, here I would like to show one more structure. So that's a parotid gland. Sometimes you'll be able to appreciate the parotid duct, which is opening to the second molar teeth, upper second molar. So there's a maxilla, and from the parotid gland, you'll be able to see a structure over the area and comes here, opening. Sometimes, not always, sometimes you will be able to see this structure. And this entire area is submandibular gland. Okay, so this is submandibular gland. Submandibular gland is medial to mandible, okay, not lateral to mandible. So further down, still we are at the level of mandible only. So this area is all submandibular space. And when you come down further, you are seeing hyoid bone. So till now it is suprahyoid. So when you see hyoid, and what is this area? Pre-epiglottic space. And this is epiglottis. So here you can see all this black is normal. And if you see any anomalies there or involvement, then you can say pre-epiglottic space is involved or not. So coming further down, now all these mandible, everything disappeared, and just see, you have to remember it is not all is not in the same plane. So when you just go down, crossing the hyoid, you are seeing the thyroid, superior corner of thyroid and the thyroid lamina. And what is this space? Paraglottic space. All clear? So that's where internal laryngeal, benign tumors of larynx, all those you will be able to see commonly there. And this is still vestibule, and coming lower down, still the paraglottic space are clearly seen. And what is this structure? Cricoid cartilage. Trachea. So here is the aortodigestive tract, that is esophagus, going more to the left side. When you go down, you can see it is more going towards the left side, and you can see a dark black, that is air within the esophagus. Can you appreciate that?
Yeah.
So when we talk about infrahyoid, now we have seen the visceral compartment, and this is the prevertebral area. And these are all small osteophytes, which can cause dysphagia sometimes. So when you go down from the thyroid cartilage level itself, you will be able to see the superior pole of the thyroid gland. You can see that on either side. When you go down, it's completely seen, and at one point you will be able to see the isthmus, and it disappears at the level of just above the level of manubrium itself. Now, till now we have not seen the manubrium, still you are seeing the clavicle, and now the manubrium comes. So it is not retrosternum. So it stops well above the level of sternum. So that's about the thyroid gland. Now, muscle, follow the sternocleidomastoid. So there's a mastoid tip. So that's a parotid gland. And inside lot of white dots, they are external carotid artery and what's the vein inside?
Retrofacial.
Retromandibular vein along with external carotid artery. You can see how it goes. Can you see that? The artery, how it comes? See, that is external carotid. Follow that. Can you follow that? How it comes into the parotid? So this is a deeper lobe, superficial lobe. So next I would like to see the sternocleidomastoid muscle. This is sternocleidomastoid muscle. So why it is important? That's how we divide anterior triangle and posterior triangle with the sternocleidomastoid muscle. So whatever the swelling you see something, whatever here or posterior triangle issues. So anything area is basically the lymph nodes are distributed along the great vessels, right? So any swelling over here, this area, most commonly it will be lymph nodes or arising from the vagus. See, depending upon the space, I'm not going to talk pathology. So depending upon the space, we have to correlate with the lesion. So you can see how sternocleidomastoid comes and attaches. So this one is trapezius, the back side. So these are all perivertebral muscles or paraspinal muscles, and this is prevertebral muscles. So we have seen suprahyoid compartment, infrahead compartment, and various spaces, visceral space, carotid space, visceral compartment. So if you go one by one, I'm sure you won't be able to miss anything. So the first step to read CT is get a software, whether it is free or install it in your system, get diagram images in a CD, load it and go through. This patient actually, the real finding I will just show you why this CT neck has been done. I don't know whether you would have appreciated it till now. Let me see whether you can find out. This is a 3D surface rendering image of this patient. This is the last one, I will stop it here.
Styloid roll.
Yes. Can you appreciate how long it is styloid? You can just rotate it and see. So the right side styloid stops here, the left side styloid almost comes down. So these all we will be able to do when you are well versed with the software. So even you can cut and see, you can remove unwanted things. So all those can be done. So with that, I stop here. If there is any questions, we can discuss later or